Welcome to The Explainer. Today we're diving into a massive problem that's hiding in plain sight, a fundamental flaw baked right into the foundations of modern medicine. It's a huge blind spot that affects the health of half the world's population. And it all starts with a question that far too many women have to ask.
Have you ever been in a doctor's office and felt like you weren't being heard? That maybe it was all in your head? Well, that feeling is incredibly common, and the data we're about to see shows it's not just a feeling. It's actually a feature of the system.
Okay, get ready for this first number. 4 years. Think about that. A huge analysis found that for the very same disease, a woman waits, on average, 4 years longer than a man to get diagnosed. That is 4 years of unnecessary pain, 4 years of uncertainty, and 4 years for a condition to get worse.
Next up, 50%. That's how much more likely a woman having a heart attack is to be misdiagnosed. And why? Because the classic heart attack symptoms we all learn about, the chest pain, the arm numbness, are overwhelmingly based on how men experience them. Women's symptoms are often totally different, and so they get missed.
And this feeling of being dismissed, it's not just a few isolated incidents. Check this out. 84%. That's the staggering number of women in the UK who say they felt unheard by their doctor. When you see a number that high, you know it's not a personal problem. It's a systemic one.
So how on earth did we get here? Well, these numbers aren't just random, unfortunate facts. They are the direct result of a deep historical flaw in how we've gathered medical knowledge. The very data that modern medicine is built on has a giant crack in its foundation.
And this core problem has a name: the gender data health gap. It sounds a little technical, but it's really simple. It's the huge difference in the amount and quality of health data we've collected for men versus women. And because of this gap, our fundamental understanding of the human body has, by default, become an understanding of the male body.
This timeline really shows you how deep the roots of this problem go. For decades, it was legal and normal to exclude women from most clinical trials in the U.S. That policy only changed in 1993. But here's the real kicker. On average, it takes 17 years for a new research finding to actually become standard practice in your doctor's office. So you do the math. The medicine being practiced today is still based on data from an era that largely ignored women.
And this isn't just some historical artifact. The bias is being built into the next generation of medicine as we speak. It starts in the lab, where most research still uses male animals. It continues into early drug trials, where women's participation is stuck at a dismal 22%. Pregnant and lactating women are almost always left out, leaving doctors to basically guess what's safe. We even saw this during the pandemic, where a huge chunk of COVID vaccine studies didn't even bother to report their results separated by sex.
So what's the actual real-world cost of all this flawed data? This is not some abstract academic debate. It has a high price, creating this terrible cascade of consequences that patients have to deal with every single day.
The result is simple and, frankly, unavoidable. When your data is overwhelmingly male, you build a medical system designed for men. It's written into the textbooks, it's taught in med schools, and it determines everything, from the symptoms doctors are trained to look for to the drugs they prescribe. The default human has become male.
Just look at this disparity in cancer care. It's jaw-dropping. After treatment, 89% of male prostate cancer patients were asked about their sexual health. For women with cervical cancer, a directly comparable situation, that number was just 13%. 13! What does that enormous gap tell you? It reveals a system that instinctively prioritizes the quality of life concerns of one gender over the other.
And this goes way beyond just the questions doctors ask. It extends to the actual treatments available. The FDA has approved 27 treatments for male sexual dysfunction. 27. For women who actually report sexual dysfunction at a rate of 40%, 2. Just 2. The first one wasn't even approved until 2015, almost 2 decades after Viagra. It's a stark picture of where the research money has been focused.
And this bias plays out in moments of crisis. In the emergency room, studies show that when women report the exact same level of abdominal pain as men, they are between 13 and 25% less likely to receive powerful opioid painkillers. Statistically, their pain is simply taken less seriously.
This constant feeling of not being believed is forcing women to take matters into their own hands. As Audrey Tsang, the co-CEO of the health app Clue, puts it, women just want to be taken seriously. They're turning to technology to collect their own data, basically building a case file of evidence just so they can advocate for themselves and get the care they need. They're trying to fill the system's data gap, one person at a time.
So just as we're finally starting to understand this historical problem, a new technology is here that threatens to make it permanent. We are on the verge of an AI revolution in healthcare, and if we're not incredibly careful, it's about to become the great amplifier of these very same biases.
Here's the critical thing you have to understand about AI. It doesn't just invent new biases from thin air. It learns from the data we give it. And if that data is biased, AI doesn't fix it. It learns the bias, it codifies it, and then it scales it at a speed and scope we have never seen before. It puts our historical inequality on an assembly line.
And this is not some distant future threat. It's happening right now. 90% of U.S. hospitals already have AI strategies in place. These systems are being deployed as we speak, trained on the very same flawed data we've been talking about. The risk of embedding this bias for decades to come is immediate and it's enormous.
There's a technical term for this. It's called algorithmic bias. It's what happens when a supposedly neutral algorithm learns from biased data. It takes our existing societal inequities and not only replicates them, but it hard-codes them into the system, creating a dangerous feedback loop that can undermine an entire healthcare system.
So how does the bias actually infect these systems? Well, it happens at every stage. It starts with historical bias, where the AI just learns the sexism that's already baked into decades of medical records. This gets worse with representation bias, because women are underrepresented in the data to begin with. Then you get aggregation bias, where a one-size-fits-all model is created that really only fits men. And finally, evaluation bias, where a tool is tested on one group, say men, but then rolled out for use on everyone. Each step is a potential point of failure.
So, is this whole situation hopeless? Absolutely not. But fixing it requires intentional, deliberate action. We can't just let a biased future happen by default. We have to actively build a fairer one. And there is a blueprint for how we can do it.
Here's a four-part blueprint for change. First, we have to demand better data. That means pushing for policies that make inclusive data collection totally non-negotiable. Second, we have to build better AI. We need independent, ethical oversight to audit algorithms for bias, not just once, but continuously. Third, listen to patients. We can use technology to harness patient-reported outcomes to finally fill the historical data gaps. And fourth, educate our professionals. Doctors and nurses have to be trained on the limits of these AI tools and on the many real ways diseases present differently across genders.
And this brings us to our final, crucial point. AI presents us with a choice. If it's used carefully, this technology could actually help us reduce these inequities. But if we're not careful, it will worsen care and lock these biases in for generations to come. The technology itself isn't good or bad. The choice of how we build it and who we build it for, that choice is on us. How will we choose?